Good morning, good afternoon, good evening, depending on where in the world you attend this webinar. My name is Karel van Looy. I'm the Global Clinical Application Manager for Breas, and I'm happy to welcome you to our second monthly webinar of our 2021 series. For the ones of you that have attended our webinar last month, you know that we will alternate 2 webinars on ventilation with 1 webinar on airway clearance, and that this series of webinars will be hosted every last Thursday of the month. Please note that the recording will become available on our educational platform, educationbybreas.com, in about a week from now. We welcome, of course, your questions during this webinar. To optimize the organization of the Q&A, I ask you to use the Q&A chat function, which you find on the right upper corner of your screen, and type in your questions there. We will address your questions at the end of Michelle's talk. All that being said, I would like to hand it over to Michelle Chatwin for her talk on the initiation of long-term mechanical ventilation. Michelle, the floor is yours.
Fabulous. Let me just check that you can see my screen. Is that all okay, Carl?
Yes, that is okay, Michelle.
Perfect. I'd like to thank Breas for asking me to do this presentation today, and Carl for your lovely introduction. As Carl said, this is the first in the ventilator series, and subsequent talks will follow by other speakers building on this scene setting experience. The aims of my presentation today are for you to understand why patients need long-term mechanical ventilation, identify which patient groups will benefit from it, to choose the correct device, mask and circuit, to initiate and adjust your ventilator settings according to your patient, and discharge and follow up your patient effectively. Before we start on how to practically do this, we need to think about why. In health, the respiratory system has ample capacity of the respiratory muscles for the load placed upon it. And normally drive is intact. However, in some conditions will affect drive, and there will be a decrease in the respiratory output, leading to decreased ventilation via the respiratory muscles and decreased tidal volumes, which will lead to an increase in carbon dioxide levels. But there are other factors that can come into play. For example, it may be that an individual has a decreased thoracic compliance, as in patients with chest wall disorders or obesity. There may be a muscle problem that affects the respiratory muscles in, for example, the muscular dystrophies and myopathies. There may be effects of the motor neurone in, for example, motor neurone disease, ALS, spinal muscular atrophy and polio. I've talked about disorders affecting respiratory control already. There may be issues with an increase in airway resistance of our chronic lung disease patients and our suppurative lung disease patients. And we may have issues of pulmonary compliance in those such as those with pulmonary edema and pulmonary fibrosis. When we're looking at a diagnosis of respiratory failure, a predictive vital capacity of less than 1 litre is particularly poor, and there is a high chance that these patients could be tipping into ventilatory failure. Of course, we can do an arterial blood gas, and if this is elevated in the day, we can commence treatment. But what we want to do is we want to look at starting and identifying patients at risk before it becomes a problem. And so we can ask about symptoms. We can ask about sleep quality. Do you sleep well? Do you wake frequently in the night? How do you feel in the morning? Do you feel like you've had a good night's sleep? Do you wake up with a headache in the morning? Do you have poor concentration throughout the day, or is it worse in the morning and gets better as the day goes on? Has their appetite changed in the morning? And if particularly in ALS patients, do they have issues with orthopnea? And because we're looking to get people before they have daytime hypercapnic respiratory failure, we can look at what happens when they sleep. Sleep is a particular stressor. When we go to sleep, we have less muscle function and we have changes in our drive. And naturally, our oxygen levels drop by a couple of percent and our carbon dioxide levels rise slightly. But in individuals where the respiratory pump is failing, we will see greater changes. And these will be firstly apparent in rapid eye movement sleep. This is when there is selective inhibition of all muscles apart from the eye and the diaphragm. And as respiratory failure and failure of the pump continues, this will be seen throughout the stages of sleep. This is a sleep study looking at carbon dioxide levels, oxygen saturation, and heart rate. And what we would expect is that someone's carbon dioxide levels would be underneath this red bar. So they would be less than 6.5 kilopascals overnight. So you can see that this patient has hypercapnia throughout the night. We would expect our oxygen saturation to be greater than 95% throughout the night. And often as people go off to sleep, we see a drop in their heart rate. And that this can then fluctuate if they are waking or having arousals. Now, the sleep study has 3 distinct periods where there is a bump or an elevation in their carbon dioxide level, and this coincides with a oxygen desaturation. And this is likely to be during periods of REM that the hypercapnic respiratory failure that you see on the sleep study is exacerbated. So what do we do? Well, we simply provide ventilatory support. And this will offload the respiratory muscles and decrease the work of breathing and hopefully, if our settings are correct, improve hypercapnic respiratory failure. So what patient groups are we looking at? Well, we have the obstructive lung disorders, for example, our COPD patients, our overlap syndrome, bronchiectasis patients, OB patients, and cystic fibrosis. We also have obesity hypoventilation syndrome, restrictive lung disease patients, and those that have parenchymal disorders, for example, kyphoscoliosis and other chest wall deformities. And we have the neuromuscular disorders and the central sleep disorders. And in these patients, the definition of the provision of long-term ventilation is providing ventilatory support for hypercapnia, which may be either nocturnal or diurnal, or in patients that fail to wean from mechanical ventilation. But as I've said, we want to preempt things. And so let's look at the ideal timing for starting long-term mechanical ventilation in neuromuscular disorders. And this study, carried out at the Brompton Hospital some years ago, was the scene setter. What they had was they had patients that had daytime hypercapnia. We know that if you are hypercapnic in the day, then your prognosis is poor. So they electively started non-invasive ventilation. We then had a group of patients that were normocapnic, and this was where it got interesting. We had a group that were randomised to control and a group that were randomised to non-invasive ventilation. And I want to have a little look at the control group, so those that were followed up with sleep studies. And this is the survival or the time in light grey that they didn't receive non-invasive ventilation, and the black bars show when they started non-invasive ventilation. And they were started because of an acute deterioration and an elevation in their carbon dioxide levels. And 70% of the patients required ventilatory support within 12 months. Subsequent to these results, it became normal that we screen our neuromuscular patients for hypercapnic respiratory failure at night, and when they start to show evidence of hypercapnic respiratory failure on sleep studies at night, we would instigate non-invasive ventilation. And we can do that around timings, for example, if they're at school, work, holidays, when they can fit it in. It doesn't need to be an emergency. Let's look at what happens now in obstructive obesity hypoventilation syndrome. If they have acute hypercapnic respiratory failure, of course, we're going to provide them with non-invasive ventilation. But we have a group that have chronic hypercapnic respiratory failure, and they can go on to have a sleep study. And if they have severe obstructive sleep apnea hyperventilation syndrome, initially we would recommend that you trial CPAP therapy, because we know that there are a group of patients with CPAP therapy that revert their hypercapnic respiratory failure. If CPAP fails, of course, you would provide non-invasive ventilation. In patients where they have no underlying sleep apnea and a low AHI, but an elevation in their carbon dioxide levels, these are ideal candidates for non-invasive ventilatory support. What do we do in COPD patients? Well, I'm sure you've all seen this data before, but this is the results of the HOT HMV study. And this looked at COPD patients' survival with home oxygen therapy plus non-invasive ventilation compared to home oxygen therapy alone. And there was a survival benefit with the addition of non-invasive ventilation. So we know that in this patient group, we will improve survival. But the interesting part is looking at how they chose their patients to meet the entry criteria for the study. And there was a significant amount of patients that were excluded. And what they did was they discharged patients after an acute exacerbation of COPD and brought them back to their clinic 2 weeks later. And in that time, a large amount of patients' blood gases had reverted to normal, meaning that they didn't need long-term provision of non-invasive ventilation. So in COPD patients, it's important to wait, bring them back to clinic and check their blood gases to see if they still require ventilatory support. We haven't touched on so much, but you can find that your patients present to you with recurrent chest infections, and this can be particularly poignant for neuromuscular patients and also children. These studies have shown that there's a decrease in hospitalisation and intensive care stay days in the time after the provision of ventilatory support. And this is something that I certainly have seen clinically, in that we have individuals that have recurrent chest infections. They don't have daytime or nighttime hypercapnic respiratory failure, but have, as I said, a neuromuscular disorder or a chronic lung disease. And the provision of ventilatory support has improved status and decreased the amount of time that they've then come into hospital afterwards. So this is the group that you may consider providing ventilatory support for. So let's just pause and summarise. The patients that we're going to be providing long-term mechanical ventilation are those that fail to wean from mechanical ventilation. If we have the presence of persistent daytime hypercapnia, if they're hypercapnic at night, if there's orthopnea in ALS patients, a vital capacity of less than a litre, and an obstructive sleep apnea hyperventilation patients, non-invasive ventilation is indicated, and if the hypercapnia doesn't resolve with CPAP therapy, they should be transferred to non-invasive ventilation. And you may decide to consider it with recurrent respiratory tract infections. What are our aims of providing ventilatory support? We know that we can potentially increase survival, but what we want to see when we're providing ventilatory support is we want to see a decreased work of breathing. We want to see this objectively. We want to see that our patients are more comfortable, that they feel less breathless, that they have less symptoms of nocturnal hypoventilation. So they're not having morning headaches, they're sleeping better, they've got an improved appetite, and you may see that after the provision of ventilatory support that weight increases. Most importantly, we want to drive down our carbon dioxide levels to within the normal range, and we will see an improvement in our oxygen saturations. We need to think about where is the most suitable place for the provision of ventilatory support. When I started, it would always be carried out as an inpatient admission, and we know that admission to hospital is traumatic for patients, that there are particular stresses on bed capacity, especially at the moment. So some years ago we looked at, and also another group looked at, whether outpatient or home initiation of non-invasive ventilation was feasible and whether it was safe. And we found in our neuromuscular patients that this was feasible and it was safe. Subsequent studies have shown that non-invasive ventilation as an outpatient and in the home is non-inferior to a hospital admission. And when we look at COPD patients, non-invasive ventilation with the addition of home monitoring was safe, and it also reduced healthcare costs. So we've chosen our patient and we've identified that they will benefit from long-term ventilatory support. And we've given them the option, depending on our setup, of whether we're going to start them at home or in the hospital as an inpatient or an outpatient. First of all, we need to think about the interface. Obviously, if our patients have a tracheostomy, we'll be using a catheter mount. But we have a whole load of masks available to us. And this is an example of non-vented masks. There are holes here which provide an intentional leak, which is where the carbon dioxide level and the waste, the air that they breathe out with the ventilator, will come out. We also have non-vented masks, which are used with active valve circuits or double limb circuits. You can see that these have blue elbows, and that these have no leak, so they cannot be used with a piece of tubing onto them straight away, because what you will do is you will have provided a circuit that doesn't allow the patient to breathe out, and that's unsafe. When we're thinking about the masks, we obviously need to think about what circuits we're going to use, and I'm going to come on to that in a minute, but most importantly, we need to think about our disease trajectory. If we have a neuromuscular patient, are they going to initially start by using ventilatory support just at night, but then move into daytime support? And if that is the case, ideally what we want to use is a mask that just covers the nose or a nasal pillow system, so that they have a clear field of view for their eyes, but they also have the ability to talk. Due to the risk of aspiration in children, we will also aim for a nasal mask first. In patients that can't keep their mouth shut or that breathe through their mouth, then obviously we will trial a full face mask. But as said, you want to think about how they will progress with their disease, because once you've started someone with a mask, they're often particularly reluctant to change. And we see that this is a problem when masks are discontinued. Patients find it very difficult to transition to an alternative. Once you've chosen your mask, it's really important that you actually read the instructions and use the sizing gauges to ensure that you have an appropriate fit. Using an inappropriate size mask has the potential to cause pressure sores and breakdown of the nasal bridge, which is particularly traumatic and sore. Also, you need to look within the instructions about whether you need to lift the mask off the face and put it back down so it's sitting on a cushion of air, and that this will improve the seal. There will also be tips about how to fit the headgear. So once you've chosen your mask, always check that you're not blocking the nostrils and that it's sitting in the right place and is the right size. Also look at whether the headgear is sitting in the right place, and teach your patient and carers, if they have carers, about where it should sit, because if it slips down or back, it will cause the mask to be uncomfortable and not seal properly. So we've chosen our mask, which will be appropriate for the type of circuit that we're using. So when it comes down to circuits, there are a lot of choices. We can have single limb circuits that don't have a leak in them, and that they can be attached to a mask with an intentional leak. We have circuits that have the ability to add an intentional leak and can be used with a non-vented mask, or we have active valve circuits which have to be used with a non-vented mask along with double circuits. And we have different widths of our circuits. And in children, particularly infants, we will be erring on using 15mm tubing to enhance triggering and more accurate ventilation, whereas in adult and older children, we will be using 22mm tubing. We also need to decide whether we will be using humidification with our patient. Often, due to resources, it may be that humidification isn't provided. Of course, it should be used in all patients with an artificial airway, but in patients using non-invasive long-term mechanical ventilation, it may not be provided initially. Often it's required in between 50 and 75% of patients, and it can be as an external module or it can be as an internal module. Let's look at the ventilator. We need to ensure that the ventilator is appropriate for our patients. As I've said about masks, are they going to be suitable for the lifetime of that patient or for that moment of their disease trajectory? But will the ventilator last for the natural history? We've said that patients are starting early, they're using it just at night. And if they're only ever going to need that ventilator at night, then you don't need one with battery provision that can do multiple modes, etc. So think about the disease history. If you're using it with a child, is it licensed for their weight and is it licensed for paediatric use? When we think about some of our restrictive chest wall disorders and our obesity hyperventilation patients, are the pressures that that device provides, are they high enough? Are you going to need to swap the device if they need higher pressures? It's not just masks that patients don't like to be swapped around. They often don't like using different ventilators. They get used to theirs and can find problems. I've touched on battery life. Is it going to have enough battery life for if it needs to go, if the patient needs to take it out and about? Does it have the right modes for the patient? Are you going to think that you might need to use a target volume mode at some point with your patient? Or are you going to need to use mouthpiece ventilation in the neuromuscular patients who are deteriorating? Again, we don't want to be swapping the ventilator. We want to provide one that will do the job and has the right programs for it. And are the alarms appropriate for your patient? And can it be mounted on a wheelchair? Let's look in some detail at the settings. So examples of modes that you will find within the ventilators are continuous positive airways pressure, or CPAP, and then you will have pressure support ventilation, which can either be a spontaneous mode where the patient triggers every breath and there is no backup, or a timed mode where the ventilator will deliver the breaths at a set time regardless of what the patient is doing. Probably more comfortable is one that does both. So spontaneous timed mode, which allows the patient to trigger the ventilator and it will provide a supported breath. And if they don't trigger the ventilator after a certain set period of time, it will deliver a timed breath. There may be some instances that patients require volume controlled ventilation so that they have a set amount of air every single breath. This mode of ventilation is not usually first choice and tends to be used in patients that you're having particular issues with. Do you want to use a mixture of pressure and targeted volume? Or do you want to use a hybrid ventilation? And that, I'm sure you've heard the terms target ventilation, IVAPs and AVAPs, but that comes under that umbrella. And as I've said, the other mode that you may find that you want to use is mouthpiece ventilation. So let's just have a little look at the differences. So continuous positive airways pressure, or CPAP, delivers a set pressure. It doesn't provide any ventilatory support on inspiration, and it will just keep the airway open on expiration. It doesn't actually ventilate the patient and is used for upper airway obstruction. If we're looking at pressure support ventilation, you will have, or you can have, on expiration, a expiratory positive airways pressure. There are devices where this can go to 0, called ZEEP or 0 IPAP. So this will hold the airway open on expiration if set. And on inspiration, it will provide a positive pressure. Most of the ventilators work between these two pressures, an IPAP and an EPAP, and is usually the first choice mode of choice for ventilators and setting up with patients. The inspiratory positive airways pressure is the set pressure that's delivered on inspiration. The expiratory positive airways pressure is the set pressure that's delivered on expiration. And as I've said, the inspiration pressure will offload the work of breathing and provide the ventilatory support, and the expiratory positive airways pressure will keep the airway open or can help with intrinsic PEEP in obstructive lung disease patients. When we look at the difference between the IPAP and the EPAP, the term that can be given is the pressure support. And you may find on some of the devices that you use, you set a PEEP, a positive end expiratory pressure, and that you set the pressure support above it, which can also be known as the IPAP. So for example, if your IPAP is 25 or your peak inspiratory pressure is 25 and your PEEP is 5, your pressure support will be 20. Often you'll want to set a backup rate. I don't think that there's any patient that I've never set a backup rate, and I'm not a fan of spontaneous mode. This is so that if the patient's respiratory rate slows or that there is an apneic period, a breath will be delivered in order for you to provide continued pressure support, ventilation at regular intervals in order to optimise your patient's oxygen and carbon dioxide levels. Other settings can include your inspiratory trigger, your rise time, and your expiratory trigger or cycling. Let's start with the inspiratory trigger. We don't want it to be too hard for the patient to get the breath in. We don't want them to be sucking really hard. But likewise, we don't want it to be so sensitive that it's delivering positive pressure all of the time that isn't coordinated with the patient. So you may want to set it to be at around 3 on Breas ventilators, or sort of at the lower end, but not too easy. When we look at rise time, this is an example of different rise times. You can see on the pressure curves that the rise time is slightly different. There is a set inspiratory time here, but the way that the breath goes in on the flow trace will be different. So if you set a fast rise time, the breath goes in quickly, it will hold for your TI, for your set inspiratory time, and then it will cycle into expiration. And that can also be changed depending on what you set your full time to be. So you can set a sharp drop off, which some patients say it stops too quickly, I don't like that, or you can lengthen it so it's mimicking more the natural flows that occur when we breathe. Setting a too high rise time can cause mask leak, and patients can say that they feel that the device is too strong. However, if the patient is particularly breathless, they will want a fast rise time. They will want the breath to be delivered and hold, and that will allow them to have optimal support. So just have a little feel of your patient. If you know that they're very breathless, set the rise time to be quite high. And if they're not so breathless, for you to set it a little bit softer so it feels more comfortable for them. And then, as I said, your TI will be set for the length of time that you want the breath to be delivered in. And potentially consider full times if your patient is particularly sensitive to the stopping of the inspiratory cycle. Let's look at devices where you can set a TI min and a TI max. And the aim of this is to improve coordination and cycling. This is your TI min and this is your TI max. What this does is it allows the breath in for a minimum period of time, and that is particularly useful if you want to ensure that your patient has a set length of a breath in and that they're not cycling into expiration too early. It means that after the patient is ready to breathe out, it will hold them in for that minimum period of time, and then it will let them cycle into expiration. If they haven't reached the pressure and that it is not noted that they're ready to breathe out, it will continue to hold them into inspiration till the end of the TI max. Where this is particularly useful is if you're having problems with leak. It will ensure that if you don't reach the pressure, that the ventilator will cycle into expiration and improve comfort for the patient. But also, if your patient takes a deep breath in, it will allow them to continue to breathe in after the TI min, so that it will support their ventilatory pattern better. Let's look at cycling or expiratory trigger. What this is looking at is your peak inspiratory flow. And if you set your cycling to be 70% of your peak inspiratory flow, the breath will be quite short because it's looking for 70% of the peak inspiratory flow, and it will allow the patient to cycle into expiration. If you're not controlling blood gases, or that the patient wants a longer breath in than what they're having, you can increase the cycling to 50% of your peak inspiratory flow, and you can see that this delivers a longer breath in. And you can further lengthen the breath by changing the cycling to 30% of the peak inspiratory flow. And this can be particularly useful when patients say that they feel the device isn't holding them in inspiration for long enough, or that they feel that the breath is too short and you haven't managed to address this by setting the inspiratory time, or that you don't have that option on your device. So let's just have a little look at where I would start. I would start my patients in a spontaneous timed mode, so that they are able to breathe away as they want to, but as they relax and go to sleep, I can ensure that they have a set backup respiratory rate in order to ensure ventilation in the most vulnerable periods of time. When setting IPAP at the start, I need to look at my patient. I need to see how big they are, whether their chest wall is very compliant. So, for example, in some neuromuscular patients, you will find that they have a particularly chest wall compliant. Chest wall compliance that's good. It hasn't particularly got stiff, and starting at an IPAP of 12 to 15 centimetres of water is absolutely fine. If you have a patient who is rather large and they're carrying excess weight around their thorax, a pressure of 12 centimetres of water is not going to be enough to lift, to allow a rise and fall of the chest wall. So I would increase that further, and you may be that you're starting at 20 or 25 centimetres of water. When it comes down to EPAP, I think that we sometimes underestimate the EPAP required. You often need to set at a minimum of 4 centimetres of water to ensure that there is flushing out of the circuit and the dead space within the mask. But what you want to do is you want to make sure that the EPAP is high enough that there isn't any upper airway obstruction. So in neuromuscular patients, you might start at 5, but you might need to increase it higher than that, especially if they complain of choking or sort of gasping, or just feel like their airway's closing a little bit at night. In obesity hyperventilation syndrome patients, you'll want to increase the EPAP to be significantly higher than that. So it might be that you're starting at 8 centimetres of water and looking to increase further. And with your COPD patients, what you're doing is you're looking at trying to match the EPAP to the level of intrinsic PEEP. And that can be somewhat difficult depending on whether they're stable state. So what you want to do is you want to ensure that they're not having to breathe out completely right the way down in order to trigger the device. So they're having to overcome their intrinsic PEEP to trigger the device. So you just need to titrate it so that you're decreasing the work of breathing and that the patient finds it more comfortable. As I've said, I would always set a backup respiratory rate, and I tend to set that personally to be a couple of breaths underneath their spontaneous respiratory rate in the day. So if they're breathing away at 20 breaths per minute, I would set them at 18 and see how they go. And I personally am a fan of setting a fixed inspiratory time, or ensuring that I'm able to set a minimum TI and a maximum TI so that I know that my patient is getting a adequate length of a breath in and that they're not necessarily cycling too fast into expiration, especially if they have a fast respiratory rate. But different people will stratify differently, and basically it depends on your patient. And so what you want to do is you want to ask them, once they've acclimatized to the mask being on their face, and for you allowed you to attach the ventilator and put some settings through, you then want to ascertain whether where you've started is appropriate. So is the breath in deep enough? What you're looking at there is the IPAP. Do you need to increase it? Do you possibly need to lengthen the inspiratory time, because that can also allow you to deliver a slightly longer breath in and more volume? Is the breath in long enough? If it's not, look at your inspiratory time or your expiratory trigger or your cycling and lengthen those. If it's too long, obviously go back the other way. Ask the patient, do they wait too long for the breath in? If they do, increase the backup rate, or look at actually, are they not able to trigger the device? Have you set the inspiratory trigger too hard? If they feel that it's coming too quickly, then you can drop things back with regards to the backup rate, but also make sure that the device isn't self-triggering. Does the breath in start before you want to breathe out? Look at the inspiratory trigger. Again, it could be self-triggering. And is the breath too difficult, or do you feel like you're choking? If that's the case, and your triggers are absolutely fine, again, is it your COPD patient that has issues with intrinsic PEEP and you need to titrate your EPAP? Or when they're asleep, do they say that they feel like they wake up choking, or that that has caused basically airway closure? And this is a good place to start to adjust your settings. And often you'll be going around and you'll be adjusting your settings. But what you want to do is you want to get to the point where you can say to the patient, does this feel comfortable enough in order for you to go home or for you to try and sleep with this device tonight? And then depending on that, you'll be further looking at adjusting settings. There are some patients that just really don't understand what you mean, and you may find that they're just very anxious about using the device. It sounds a little bit odd, but in those individuals, I try and get them to relax as much as possible. And I'll tell them, have a breath in, and then I just want you to wait, and then the ventilator will deliver a breath. And that can help to improve confidence, that they know that the ventilator isn't going to take over. It's not going to blow them up, as they say, and that they feel that the ventilator derived breaths are fine, and that will allow them to relax more so that the ventilator can take over. So once you've got to them to a point, you're evaluating things, and what you want to see is there a decreased work of breathing? Have they relaxed their shoulders? Do they feel like that the ventilator is coming at the right time? Conversely, you want to make sure that you are seeing a good rise and fall of the chest wall that is in time with the ventilator. So you want to make sure that your IPAP is high enough that it is actually providing a breath into the lungs, and that the timing and the settings are right, that you decrease the work of breathing. And if you do that, the patient should feel less breathless. If they are able to sleep with it for a proportion of time, and that's usually over 4 hours, they should feel better symptomatically. You should see improvements in oxygen saturation, and you should see that their carbon dioxide levels are starting to normalise. And this may take some time. It doesn't necessarily happen overnight. So it may be that you wait a few days before performing a sleep study, or it may be that you perform one that night to see where you are. And in this sleep study, after the initiation of ventilatory support, you can see that the oxygen saturation is greater than 95% and stable for the night. The heart rate has dropped so that they are sleeping. There is some fluctuation around, but they go off to sleep. And as they've gone off to sleep, there is a slight elevation in the carbon dioxide level, but it's not nearly as bad as the sleep study that you saw at the start. So this is a good response to ventilation, but it's not optimal, and you would want to go back to your patient and see if you can increase the inspiratory positive airways pressure to bring this carbon dioxide levels down a little bit more. You may be able to, if they don't want the pressure to be increased, work on the rate a little bit. Can you speed it up to increase their minute ventilation? And just look to make sure that you're capturing their inspiratory times. So we're looking for improvements in oxygen and carbon dioxide levels, and we're also looking that we've made them sleep better. And what we're doing is we're aiming for at least 4 hours per night. We know in ALS patients that if we can get our patients using their ventilator for more than 4 hours a night, that they will have an improvement in their survival. And this has also been seen in other groups of patients. From early work from Annabelle Nicol some years ago, in order to decrease symptoms and correct drive, you needed in COPD patients also to have greater than 4 hours per night use. So this 4 hours per night, although it tends to come from the sleep background, we are now seeing in our ventilated patients that using it for more than that improves survival, but ideally if they can use it even longer, you will find that there will be a further survival benefit. Let's just spend a few moments looking at the potential problems that you could see, and they may be non-intentional leaks due to mouth breathing with a nasal mask. You can swap them to a chin strap or consider an oronasal interface. Make sure they're not over tightening the straps. This can often produce leak. That you've incorrectly sized your mask. Go back to using the gauge. If they have an unusual face shape, consider mask rotation because that can change the pressure points. If they have persistent hypoxia, look again for leak. They may have an insufficient time on non-invasive ventilation. If they're only using it 1 or 2 hours, that's probably that won't be enough for them, and you want to reassure them and educate them that they need it for longer. You may have tried not to use supplementary oxygen therapy, or it's been insufficient. So titrate the oxygen to the level that is required, ensuring that you're not causing an abnormal rise in the CO2. And also look, is there collapse of the lower airways? Do we need to increase our IPAP to help with that? And a key one is looking at patient ventilator asynchrony. So review your settings, look at the waveforms. Are you finding that the patient is completely asynchronous with the ventilator? When we look at it, what happens if we've got persistent hypercapnia? Usually you can find that it's due to mask leak and we're not ventilating properly. The second most common reason is that they're not using the ventilator enough. And again, reassure and re-educate. Our pressure support might be too low, so we would try to increase that. And if the patient doesn't tolerate an increase in pressure support, look at titrating the inspiratory time or the backup breaths per minute. Make sure we're not giving too much oxygen. As I've said, look at patient ventilator asynchrony on ventilator download and just check that they're not CO2 rebreathing. You never know. Some patients manage to put a non-vented mask straight on their tubing. If the CO2, if the circuit is absolutely fine and you cannot alter your pressures any further, you might want to consider using an active valve circuit. There are some instances that despite everything you've done, you cannot improve things. And it may be that your patient has changes in their pulmonary compliance and that, or in the positional compliance of their chest wall. And in that instant, you might decide that you want to try hybrid ventilation. And hybrid ventilation allows you to set a target volume that you want to be delivered. And it will vary the IPAP according to that level. So as the volumes drop, it will increase the pressure support in order to try and maintain that. And some devices will also allow titration of the expiratory positive airways pressure in the event of upper airway obstruction. There's no evidence to say that this mode of ventilation is better than standard modes of ventilation, but it can be useful in patients that you find are not responding. The key thing with hybrid ventilation is that if you have mask leak, it is going to be ineffective because it cannot get an accurate measure of what is going on with the volumes that you're trying to target. I mentioned that devices can change the EPAP depending on what's happening with the upper airway, and this is often called auto EPAP. It aims to reduce upper airway obstruction or flow limitation. So when you're setting your EPAP, if the upper airway is a problem, it may be that you choose to allow your device to run between a minimum and a maximum EPAP so that the device can maintain a patent upper airway. However, if there is an issue with tracheomalacia, then using auto EPAP is not the mode of choice, and the same with issues around intrinsic PEEP. We also need to think about discharge. It's not just about providing someone with a ventilator, a mask and a piece of tubing. You need to think about ancillary equipment. And we know that providing MIE devices in ALS patients improves survival greater than just ventilation alone. We need to provide education and training, and I think we really need to adapt what we're doing. So it's not just about providing a load of written information. It may be that we're using videos, that we're providing remote links and reviewing patients via videos. We need to make an assessment of knowledge and practical skills. And this should be assessed and looked at how often it should be reassessed. We need to think about looking at, do we need to monitor our patients at home? And I think the COVID-19 pandemic has driven this forward, and it has been especially useful because it allows us to find out whether our patients are actually trying to use the ventilator. So here they're trying to use it, but they're not able to use it for more than 4 hours. This patient is blipping between under 4 hours and over 4 hours, but there are problems. And this is the patient that we like to see, that we don't need to input. But it gives us information about what are we seeing? Why could this patient perhaps not be using it? And in this individual, there is a high leak. So what we would want to do is address this quickly to help improve things, because we don't want them to not use it at all. And we don't want them to have good nights and bad nights. We can also see patients that are having fragmented nights and find out why that might be. And it might be something as simple as they're having to come off and drink water because they're getting very dry. One other thing you may see is that the usage increases as time goes on, and that that would indicate that we would want to review the patient, because it may be that their settings aren't correct or that they're deteriorating. So underusage is just as important as overusage. So in summary, starting long-term mechanical ventilation may be simple or it may be complex. When considering masks and ventilators, we need to think about the disease progression. We need to provide humidification as required, and we should start with simple modes and consider more complex modes when we're unable to correct carbon dioxide levels. Titrate our settings to the patient, aiming to improve our arterial blood gases and decrease work of breathing and symptoms. And we should evaluate the efficacy with sleep studies and home monitoring. And I can probably talk for a whole nother hour on discharge planning and information, but it is essential that you get it right. So I'd like to thank you for your attention and ask you to put any questions in the Q&A chat. If you're watching this on catch up or you don't get a chance to have your question answered, please do feel free to email